Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Si Chen, Physician Director of Practice Sustainability here at the AMA. To discuss his experience in behavioral healthcare, I'm joined by our guest, Dr. Robert Cooley, Associate Professor in Primary Care Medicine at Kansas City University College of Osteopathic Medicine. Dr. Cooley, thank you so much for being here today and discussing this excellent topic.
Thank you for having me. I'm looking forward to it.
Before we get started, would you mind telling our listeners a little bit about yourself and your background?
Yeah, I'm an associate professor of medicine, like you said, board certified family medicine, board certified in addiction medicine. And before I started medical school, I worked as a clinical psychologist. I think my background, I should include that I was a certified alcohol and drug counselor to work my way through my senior year in college and then all the way through graduate school. And I think that kind of influenced some of my thinking and perceptions about addictions treatment. I've been medical director of, 4 different alcohol and drug residential rehab centers, and I've kind of specialized in behavioral medicine throughout my career.
You spoke about your experience as an alcohol and drug counselor prior to entering medical school. Did you do this during graduate school, or did you do this beforehand?
It started in my senior year in college, undergraduate. And I wanted to build my resume. I already had an interest in psychology, but I think that kind of gets into sort of my personal history, which I'm comfortable talking about. I think it's relevant. I was a patient at the Menninger Clinic when I was 17 years old. Actually, I got admitted just before my 17th birthday. I was one of those kids who was having a lot of problems going to school. I was in the spectrum, and in those days, it wasn't even a diagnosis. And in those days in Texas, you couldn't refuse school. That was considered to be criminal activity. I was a juvenile delinquent. So I was having a lot of depression and anxiety, and my parents arranged for me to be sent to the Menninger Clinic in Topeka, Kansas. And I think that was a huge step, tremendously helpful, long-term treatment. And then later, after I got out of graduate school, the Menninger Clinic hired me to work as a counselor with the children and adolescents in the hospital. And then I also started the addiction-related services for them. So all those things kind of got intertwined, but it was my interest in behavioral medicine and my relationship with one of my mentors, Dr. George Penn, who was a psychiatrist who I worked with when I was at the Menninger Clinic as a patient, was also a medical director of an addictions rehab program and got me interested in that form of treatment. And he also worked as medical director at the place where I was working as a counselor. It was that mentorship from George Penn, a psychiatrist, who also took care of the patient's primary care needs. He was the one that treated their strep throat, or you got them on their diabetes medications and whatever. He had to play 2 roles in that particular setting. And I think that hugely influenced my trajectory.
Well, thank you for sharing such a vulnerable experience in your life, but I think it really highlights how these last few years we've started to, or at least continued that destigmatization of behavioral health issues. And so appreciate that greatly.
Thank you.
So I know that you just talked about your mentor and how he was a psychiatrist, but he also took care of the medical and physical ailments that his patients had. Ultimately, how did you decide from going from being a psychologist, a clinical psychologist, and sort of going down that path as a medical physician?
I think part of it is, my dad was an MD. My mom was a psychiatric nurse. She was head nurse at Johns Hopkins Psychiatric Unit, where she met my dad. And then so just over the years, just listening and talk about patients over at the dinner table, I realized that there was this need to bring those 2 approaches together. And I think it slowly evolved over time. When I was in graduate school, I wrote a thesis on incorporating psychological principles and techniques into family medicine. At that time, my professor said, "Oh, that'll never happen. They do physical exams and they make medical diagnoses, but I don't think they have time to do any of that other stuff. And I thought, yeah, if they could use motivational interviewing and some brief interventional therapies, they could probably get some better compliance. But I wrote that paper. And then when I was at the Medicare clinic working, I started an addictions related services for them. They didn't have an inpatient service to bring that kind of treatment to the patients that were already in the hospital. They waited till they were discharged and then sent them to a short-term, I'll call them drug program. When I was working at the Medicare clinic, the chief of staff at the Children's Adolescent Hospital was a pediatrician, not a psychiatrist. And one of the unit directors was a pediatrician because they could address the physical needs, the medical needs of those patients while they were in treatment. And I was trying to do some research on the sort of correlates, EEG correlates of alcohol and drug use disorder behavior, and found that there was a connection with when we did transesophageal EEGs, that there was fast wave alpha with a lot of these kids that were coming in that had alcohol and drug issues. There was a couple of residents there at the Medicare clinic who said, if you want to pursue this kind of research and do the kinds of things you're talking about, you're going to have to go to medical school. And they were from KCU. So I applied and went to KCU. It's just something that kind of evolved. And it just seemed to be the natural thing for me to take this, what I thought was important, to another level.
That's great. I think that, you've given us a great sort of background as to how you got to medical school and went through medical school. After you started practice, can you tell us an experience that illustrates like the benefits of an integrated approach as you've been talking about to patient care? Something that either you've seen in your clinic or you've witnessed. What are those experiences that sort of hit home for you that say, hey, the integrated approach is the right way to go?
Well, there were several things, I think, because I would just talk forever about it. But when I was at one of the community clinics here in the Kansas City area, there was a great need in the psychiatric department to have somebody fill in because two of the providers were out. So the director of the department came down and talked to me. Somehow he heard that I'd had this background at the Medicare clinic, working with children and adolescents and inpatient psychiatric patients. And he asked me to fill in. He said, I will supervise you. I will give you all the information you need. I'll give you all the support you need, but we are desperate. We need help functioning as a psychiatrist, even though I'm not a board certified psychiatrist. And he taught me a lot. And then he told me about a place where another behavioral health center that needed a prescriber where they didn't have any child and adolescent prescribers. And I applied there. I told them about my background. They said, fine. When I was there working with the child and adolescent population, I realized so many of these psychiatric diagnoses were actually related to health issues other than the psychiatric diagnosis. And in fact, some of the psychiatric diagnoses probably weren't even accurate. For instance, kids brought in because there were concerns about ADHD. And some of them had already started on Ritalin or whatever. Found out they had nighttime variant asthma. They had nocturnal enuresis. They weren't getting good meals. No behavioral modification techniques had been initiated. So some of these kids really didn't even have ADHD. Once we got their asthma under control or got their nocturnal enuresis under control or their sleep disturbances under control, oftentimes we realized they didn't really even have ADHD. And it was a matter of treating them for that. And then I found there were times when some of the child and adolescent psychiatrists had long since given up using their stethoscopes and had been doing primary care. So when they had abnormal labs or they had concerns about a family history of cardiac arrhythmias and they wanted to start a kid on a stimulant, they referred the patient over to me so that I could evaluate them. What was really interesting at that time, if I wanted to do that, I had to take that child out of my office down the hall to the primary care clinic in a clinic next door, check them in over there, and then do the evaluation there, do the EKG, whatever, type the report up, and then walk back over to my office and then give the report to their primary psychiatrist. So it just drove home the importance of integrating this care. I thought it could be done. And another case, when I was at the Health Partnership Clinic, just as an example, there was a man with schizoaffective disorder who did quite well most of the time when he kept his diabetes well managed. But we noticed a pattern about 6 months in that when he came in and said he was hearing voices again and he was being distracted and his family was telling him that he was completely off base with some things and getting feedback that he was delusional, he kept insisting that we increase his psych meds. And we said, well, no, your hemoglobin A1C has gone up to 11. So every time we got his hemoglobin A1C back down to 7 or below, he was almost symptom-free from his schizoaffective disorder without having to increase his atypical antipsychotic.
Dr. Cooley, I think you've illustrated beautifully that interrelationship between behavioral health and physical health. Now, there's obviously a lot of interplay between each. And so it sounds to me like your integrated approach really keeps that in very sharp focus. And so I think in my experience as a radiation oncologist, we are typically focused in on just treating the cancer. And if there's any issues with behavioral health, which of course, patients that are undergoing cancer care can certainly suffer from, a lot of our gut reaction is to send them down the street to a psychiatrist. But if we can have in-office care with these patients, I think it just provides them so much of a higher level of compassion and service. So kudos to how you've been able to bring those two together. Speaking of, these complex physical ailments like cancer, like grave disorders that are medical in nature, with corresponding or with comorbid behavioral issues, behavioral ailments, how do you sort of balance the two in this integrated care model, especially if you're the physician that is treating both, as you would be?
I think over the years as I matured some personally and learned how to remove my ego from situations, I was able to sit with patients and start talking to them about what they really needed and what they wanted. I realized that a lot of patients weren't really willing to do some of the things that doctors prescribed for them or recommended for them, but didn't feel free to discuss that in the visit they had with the doctor. So I learned more and more over time how to use motivational interviewing, which particularly with people with very serious illnesses and potentially life-threatening illnesses, I think developing a sense of shared decision-making has been super important. And being aware of what all the different treatments are and their potential interactions and discussing those with the patient. I know some patients that are undergoing treatment for cancer, having survived cancer twice in my lifetime, that I know there's a lot of interactions that sometimes the psychiatrist isn't aware of. There's a lot of potential 3A4 drug-drug interactions that can cause QT prolongations and so forth. Some patients don't metabolize 2D6 medications as well, and they feel a little bit sick. They feel a little nauseated. They feel extremely fatigued. The quality of life is going down. So I think it's important just to meet with every single patient as a unique case and figure out what that patient wants to prioritize.
That's great. I think you've highlighted the importance of listening to the patient and being a patient-centered physician. And I think that that's something that we all need to keep in mind. Changing gears a little bit, I know that you started a behavioral medicine honors track at KCU. What inspired you to create this program, and what do you hope that students can gain from the program?
Well, things have changed since I was in training, and I've been aware of a really increasing kind of mental health crisis in the United States. And I've been keeping up on these articles that are written by all these think tanks and JAMA and AOA and so forth, and thinking about solutions for that. And it seems like the Behavioral Health Integration Collaborative is one of the most positive movements that I've seen. And I thought, well, what we need to do is get medical students oriented towards the importance of behavioral medicine from the get-go. So we wanted to have a course that went through all 4 years where they could find ways, whether they want to be a psychiatrist or a family medicine doctor, that they can find ways to learn more about it and how to collaborate. So we're going to teach them about interprofessional collaboration using the core competencies of IPEC. And we're going to be talking about the models that are used in clinics like a co-located psychiatrist who receives warm handoffs from the primary care doctor while they're in the clinic. We want to get that orientation started early so it can carry through the rest of their training.
You mentioned IPEC. Could you tell our listeners what that stands for?
That's an international association that promotes interprofessional education and collaboration. And I believe they have 22 affiliated associations like the American Association of Medical Colleges, the American Psychological Association, American Nursing Association, and so forth, that have put together guidelines for what constitutes best practices for interprofessional cooperation, coordination, and collaboration.
You mentioned collaborative care models and other models of care. How do you think these integrated care models can help address some of the broader healthcare challenges that we have in the landscape today?
Well, we know that a lot of the behavioral health issues, where a lot of the underserved areas are in deep urban areas and in rural areas. And there just aren't enough psychiatrists like my old mentor, George Penn, to go around. Even though he was willing to step out of his comfort zone and practice primary care as part of his psychiatric practice, and especially in the clinics that he worked in, there's just not enough to go around. So we know that we can spread their expertise further if we can teach family medicine doctors, pediatricians, internal medicine doctors, OBGYN doctors how to collaborate with a single psychiatrist who's associated with their clinic.
That's wonderful. I know that shortage is felt by many in those underserved areas. So I think that this is a great way to think about how to improve things for the future, hopefully the short-term future. That being said, those physicians in training, residents, what advice would you give those future clinicians who are interested in pursuing some of this more integrated whole person kind of care?
Well, I know that there's been updates in the residency requirements for family medicine residencies. Now they are actually required to have some formal psychiatric training, and they have to show that they've actually managed some psychiatric patients. But also, myself and my colleagues are advocating for a behavioral medicine certification program similar to the addiction medicine certification that's available for primary care physicians now. And it may mean that residents might have to do a year fellowship in a behavioral medicine clinic, or there may be another route that they can take where they can work in a clinic and get supervised hours and document that and then take a board exam. But I know that the training, it's already being incorporated into at least the family medicine residencies. If people are interested in it, though, I think getting a master's in clinical psychology was extremely helpful for me to understand psychiatry. And understanding what the behavioral health consultant is telling me, I need to know what a psychometric exam is and then what it tests for. And I found that those psychometric tests can be helpful with making medical diagnoses. We had a patient that came in that had an aneurysm clipping in his right frontal lobe, and then started having some really unusual left-sided paresis. And through psychometric testing, we were able to isolate where the cognitive deficits were on the psychometric testing, and it corresponded with the area of clipping, and we diagnosed him with a partial seizure complex disorder and went on from there. So I know having that kind of training, which you can get through a lot of the medical schools now. We have a health services psychology program with our medical school, and there's also online programs that you can get involved in.
Wonderful. Wrapping up today, are there any other pearls of wisdom that you would like to share with our audience members?
Well, I don't know if I have that much wisdom to share, but
I'm sure that's not true.
I think that it's just for family medicine doctors who have not tried to practice any psychiatry that they've referred out. I think that they've seen that it's become harder and harder to get patients in. And I think that if you look at the Behavioral Integration Collaborative, they have a compendium that they've published and sent out. And if you study that, it will give you all the resources that you need to help you with your practice.
Thank you for calling that out. That resource is something that the AMA and the collaborative have put together. And I think it's a very valuable resource for all of physicians, not just primary care, but even us non-primary care specialties. And so thank you for this wonderful conversation. Thank you for all of your insights and sharing your experiences. Dr. Robert Cooley has been our guest today. Check out the episode description to explore the resources mentioned in today's episode. So thank you so much, Dr. Cooley.
Thank you.
Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.